One of the key controversies in colorectal cancer screening is that we have multiple tests with which to screen patients, supported by randomized trial evidence, particularly fecal blood testing and also sigmoidoscopy, and by extrapolation, some idea that colonoscopy is also effective for patients. We had questions about what the best way to screen our patients would be, but no one had done a trial, and we couldn't imagine a trial being done in the near future or being completed in the near future to look at people moving through different types of screening at different points in their age.
A good model can answer a lot of questions at a much shorter time at much lower cost. And you can also use model to optimize your treatment guideline, your screening guideline to maximize the benefits for the patient at a lower cost.
So one of the key highlights is that having people do fecal immunochemical test screening annually from 50 to 65, and then transitioning to colonoscopy, perhaps one-time colonoscopy at the age of 66, yielded very similar health benefits as having people do colonoscopy every 10 years over the course of their life from 50 to 75. And so the advantage of that for patients would be many fewer colonoscopies would be needed with attendant less risk of complications and lower costs even to them in terms of missed time from work or other inconvenience. Simulation models have been done, notably by Ann Zauber and her colleagues with the MyScan simulation, and they showed that very similar health benefits are achieved with either doing colonoscopy alone every 10 years or doing higher sensitivity fecal blood testing like the FIT test every year. So where we advance the field is introducing the idea that people might do one form of screening for their younger ages where they might be at lower risk for colon cancer, and as they age and accumulate higher risk, doing colonoscopy, which may be more invasive, that can still also yield similar results and as doing colonoscopy all the way through the whole life cycle. So the Kaiser Permanente program for screening is really based on outreach with FIT testing to people who have not had screening ordered through their primary care provider. And at the primary care provider level, patients can have either colonoscopy or FIT for screening. And we're using FIT as a way to capture people into the screening program who've not been screened by any other method. One of the issues with colonoscopy versus FIT screening is that patient acceptance plays a big role. And there's a lot of patients who are willing to do FIT test, but maybe potentially unwilling to do colonoscopy. So that patient choice and patient willingness to screen plays a huge role. Two recent randomized trials have looked at patient acceptance of screening when people are offered either fecal blood screening or colonoscopy, and have seen that offering only colonoscopy to people results in many fewer people actually being screened than offering people either a choice of fecal screening and colonoscopy or offering them just fecal screening alone. And our program is continually evolving. We're continually looking at ways to screen more people, deliver the screening with higher quality, including the quality of the colonoscopies that are being done, as well as also closing disparities between ethnic groups that are maybe underrepresented in the screening pool, as opposed to our white patients who have higher screening rates. Latinos and African Americans have lower screening rates, and we're actively looking at ways to close that gap as well.